Very good afternoon and welcome to the session on the topic tumor in uterus and ovary. We are glad to have Dr. Aparna Jha from Apollo Cradles and Children Hospital, Marathili. We welcome you, ma'am. So, everyone, please stay tuned to the last because we'll be taking all your questions and queries by the last of the session. If you have any doubts, post that on the comment section so that we can take and our doctor can answer you. Over to you, ma'am.
Thank you for the warm welcome. Hello, everyone. I am Dr. Aparna Jha, Senior Gynecologist working in Apollo Cradle, Brookfield or Marathali. I'm extremely sorry I was delayed for because of a case for 15 minutes. In fact, coincidentally, this is the same case what I'm going to talk to you about. One of the scenarios which I'm going to talk to you about today. So today's my topic is tumor in ovary and uterus. Uh, Uterus and the ovary, as you all understand, is the vital organ or is the most vital reproductive organ of the female system. Now, when we get very often almost 30% of the OPD load is because of either there's a cyst in the ovary or there's a fibroid in the uterus, and the patient comes panicking to us asking whether it is a cancerous one or not one. Do we have to wait for on this tumor, or do we have to get a surgery done immediately? Is there any complication or not? So there are lot of questions, and there are a lot of things to answer. I would take up all the questions at the end. Before that, I would want to have a extensive session, so that I would make sure that your doubts are cleared there. But still, despite of that, if you have some doubts, you are most welcome to ask me at the end of the session. Now let's come back to this, that the ovary and the uterus. So there is a uterus in between, and besides the uterus, there are two fallopian tube which are like a thread, and then with the fallopian tube, there's this ovary. There are these two ovaries. Okay, so there's one uterus, there's two fallopian tube, and there are two ovaries. Okay, this is the one which is the reproductive system as such. I would start with the tumors or the masses of the uterus first, and then I would go to the ovary. Uh, Now, uterus, or rather, let me do the other way around. Let me first start with the ovarian masses first, or ovarian tumors first, and then I would go to the uterine masses. I will tell you why at the end of the session. Now, ovarian masses generally, uh, tumors of the ovary. Tumor word does not mean that it is always a large, big mass and with cancerous tendency or with malignancy into it. Any kind of, even if it is like a small bubble kind of thing, then also we call it as small tumor or small cyst. If it is big, then yes, of course, in regular language we start calling it as there's a tumor, or there's a problem in the ovary. When we say tumor, that does not mean on its own that there's a malignancy. We still need to rule it out. So when we see a cyst or a mass in the ovary, we first want to figure out whether it is a simple mass or a simple cyst, or it is a complex cyst or a complex mass. Now, there are some criteria for in medical language when we look into those, like the size of the mass, like the content, so-called, when we get a scan done, whether the scan shows that there's a very, very free fluid, liquid kind of watery kind of content inside the mass. What is the complaint of the patient? How's the patient perceiving it? Putting all this together, we divide it into simple and complex. This are all I'm talking about ovarian mass again. So simple cyst, generally, even if the size is a little bigger, smaller simple cyst, anything less than 4 or 5 centimeter, we worry nowhere about it. Do not panic about it. There are simple cysts which get formed every month or every 2 or 3 months in your ovary. Sometimes you get to know it because if you've got a scan at that time. Sometimes you don't get to know it because by within next 2 to 3 months, these masses, they just shrink off. We also call them as functional cysts. They come up and they disappear. So a simple cyst, which is, even if it is a little bigger in size, we really don't worry about it. So anything which is above 5 or 6 centimeter, even if it is simple, probably then we need to evaluate it further. Now coming to complex cyst. So there are many of the times when my sonologist or my radiologist, they write a entity called complex cyst. It means that the cyst has something beyond to clear liquid, beyond to water, beyond to serous fluid. It has something else. It could be blood, it could be some solid mass, or it could be some debris, it could be many more things. Okay, so if that kind of word is used, that if it is a complex cyst, then we definitely need to rule it out, that are we dealing with a regular complex cyst? Again, not all the complex cysts or not all the hemorrhagic cysts are cancerous. In fact, very few of them. If I am seeing a cyst in 100 females, for example, out of that only 3 or 4 will be cancerous. So out of 100, only 3 or 4 will be cancerous. So we really do not worry only about cancer. Yes, that is the dreaded thing, but then there are beyond to, before that there are many more things which we need to look upon. Now, when we know that it is a complex cyst, what we want to know about it is that whether it is a hemorrhagic, whether the liquid inside the cyst or whether the content inside the cyst is a regular blood, which we call it as hemorrhagic cyst, or a old blood or clotted blood, what we call it as endometriotic or chocolate cyst, or if there are some solid masses inside it, some different kind of debris, like sometimes we can have as surprising as a tooth inside it, as surprising as some hair follicles, hairs inside it, what we call it as dermoid cyst. And the last one is those cysts wherein all these kind of contents are mixed. We do not know exactly what kind of cyst it is, whether it is a cancerous one or a non-cancerous one. So once we look upon the cyst in ultrasound, once we do our physical examination, we to a large extent, to 60 to 70% of the extent, we know that what kind of cyst it is. 60% of the time. Rest 40% of the time we need to do the further test and then we need to figure it out. So if it is, again, if it is a hemorrhagic cyst, then we wait and watch. Hemorrhagic cysts are something which may disappear in couple of cycles, may or may not. If the size of the cyst is not increasing, then we can still wait and watch, and then we can take a call about it if we have to be operating them upon or not. There is another entity which is called as endometriotic cyst or a chocolate cyst, which sometimes looks like a hemorrhagic cyst. Though hemorrhagic cyst has more fresh blood into it, endometriotic cyst has a bit of clots into it, more of clots or more of uh, uh, thick blood into it. Still, it may be at times confusing. Now, endometriotic cyst, do we have to? What next has to be done? That is again, that's a different entity. We have to look at the patient's age, signs, symptoms, whether she is conceived or not, what she wants, whether she wants conception, what is her symptom, whether she has much of pain or is she comfortable, uncomfortable with the pain, many things, and then we decide about the treatment of endometriotic cyst. Now, the cysts which are of unknown origin, I mean unknown etiology, wherein we are unable to say whether the cyst is because, I mean, whether it is a hemorrhagic one, whether it is endometriotic, whether it is dermoid, or whether it is something different. There we need to evaluate. We further go ahead and get some of the tests done, some blood tests done. Sometimes we may have to do a CT scan or an MRI to figure out whether the cyst is, what kind of cyst it is, whether it is more towards a benign or non-cancerous, or it is more towards a cancerous cyst. Age is a very important factor in ovarian cyst. The same cyst which may look nowhere concerning to us, like at the age of a 25 or 26 or 28-year-old female, if I see a hemorrhagic cyst of 3 to 4 centimeter, I would say her to wait. But the same kind of cyst, if I'm seeing in a postmenopausal lady, like a lady who is more than 56 or 60 years, then it is a concern. So age is a major concern in ovarian cyst. Any cyst which has uh, originated after certain age, after the age of 50 or 55, or certainly after the age of postmenopause, is to be evaluated. we do not, even if the cyst size is very small, still we do not let it be unevaluated if the female has developed with it post-menopausal. So after menopause, the ovarian cyst has to be definitely evaluated. And once we evaluate the cyst, once we know that it is more so a benign mass or a non-cancerous mass, and if the mass is, if mass is causing symptoms to the patient, then we generally take those masses out. Now, coming to the, and if it is, of course, if it is a cancerous mass, then the treatment plan goes a little different. Now, coming to the treatment of the ovarian cysts, if at all, like there are 40 to 50% of them in which we can wait and watch. We tell the patient to follow up with us. You have to get ultrasound done after 6 months, after 3 months, looking at the size, looking at the growth of the mass. We decide whether we have to again put any, have to investigate or have to put any surgical intervention or not. If at all we decide about going for a surgical intervention, generally it is a laparoscopic procedure wherein we put a small cut at the navel area and one or two further cuts, and then we take the cyst out. Most of the time, the cyst can be laparoscopically, it can be taken out. Once we have taken out the cyst, after that, depending upon what kind of cyst, whatever the cyst I have talked to you about earlier, depending upon what kind of cyst, we have to have the follow up with the patient. Sometimes we say the patient not to worry about it at all because it may not mostly come back. Sometimes we tell the patient that yes, you will have to again redo a scan after 6 months or 1 year. Sometimes we tell the patient that yes, we have removed this cyst, like endometriotic cyst. Once we remove it, and if the patient is not conceived, we tell the patient to conceive as soon as possible. So this was more or less all about the cyst of the ovary. Now, mind you, I'm not talking about polycystic ovary right now here, because PCOD or polycystic ovarian disease is a different type of cyst. We do not consider that as one of the tumors of the ovary, because those cysts, they generally cause hormonal imbalance. Per se, the cyst size or the cyst would not cause a trouble to the female. Now, coming to the uterine mass or uterine cysts, ovaries, uterine tumors. Uterus can again have multiple types of tumors, but uterine tumors do not vary so much like ovarian. Like it doesn't have anything called simple or complex, or it doesn't have a cystic entity more. Uterine masses are generally, either a fibroid, which is 99% of the time non-malignant, but it is wrong to say that fibroid can never grow towards cancer. Fibroids, long-standing fibroid, may develop as fibrosarcoma. So if there is a very long-standing fibroid, that has to be looked upon from that perspective also. But generally, 99% of the fibroids are non-cancerous. Fibroid is one of the most common tumor of the uterus. In fact, fibroid is one of the most common tumor in the whole reproductive system of the female. Beyond to fibroid, there is something called adenomyosis or adenomyotic mass, which we see very commonly common in those cases who have already an endometriosis or an endometriotic cyst or a chocolate cyst. How do we figure out that whether it is an adenomyotic mass or a fibroid? It is about the symptoms of the patients. It is about the signs of the patient. And to an extent, we get an ultrasound finding wherein we are able to differentiate between a fibroid of the, a fibroid or a adenomyotic mass. So these two are in general the common ones. Fibroid is much more common than adenomyosis. There are some tumors which we do not exactly call it as from the uterus, but it could be from the inner part of the uterus, what we call it as submucosal fibroid again, or an endometriotic polyp. These are mucosal, small grape-like vesicles kind of thing, which are hanging in the endometrial cavity, which may cause excessive bleeding or spotting kind of thing time and again into the patient. Fibroids, the symptoms, most of the time fibroids are asymptomatic. They do not cause much of the problems, but sometimes if the fibroids are big in size, they may cause bleeding more. They may cause irregular periods. They may also could be the cause of pain abdomen or stretching of the tummy, or sometimes bladder symptoms like, patient may feel like going for urination quite a lot of time. Sometimes fibroid may also cause the reason, maybe the reason of constipation or severe abdominal bloating and sensations like that. So if the fibroids are symptomatic, if all these symptoms are there, you need to visit to your doctor, ask her if you need treatment in terms of any medical management or surgical intervention. Again, if there is a need of surgical intervention, generally if the fibroid is really very not humongous in size, a very huge fibroid, that can be taken care by a laparoscopic surgery. The another part of this was adenomyotic mass, which I talked to you about. Adenomyosis or adenomyotic masses are generally symptomatic ones. Patient will have a lot of pain in her tummy. She'll have a lot of bleeding during her cycle. Her periods are very painful, very heavy cycles. So in those cases, again, depending upon the age of the patient and depending upon the need, fertility need of the patient, we treat the patient. Sometimes the adenomyotic masses could be just having mild to moderate symptom, wherein we do nothing much, or we give some hormonal pills to the patient and patient is comfortable. Sometimes we use a product called Mirena or Coppity, which we put, I mean, it's a Coppity kind of device, what we call it as Mirena. That also helps in adenomyotic masses. And sometimes if the patient has completed her family and she's above 45 years old, or and she's having a lot of pain and bleeding, we do also take care, I mean, take the uterus out in adenomyotic masses. Endometrial polyps are something which are if they are being symptomatic, we see every now and then endometriotic polyp. Unless the polyp is causing a symptom, or unless the polyp is causing any kind of bleeding, spotting, we really do not go and touch the polyps. Or if the patient is trying to conceive, into those conditions, we may have to do surgical intervention for those polyps. Otherwise, we do not do much of treatment for the polyp. And coming to endometriotic cancer. Now, endometriotic cancer, again, like the way ovarian cancer may mimic a normal ovarian cyst also, ovarian endometrial cancer do not mimic a normal regular fibroid or a normal regular adenomyosis. Most of the time, endometrial cancer is towards the inner layer of the uterus, wherein the other part of other tumors we do not see, like the fibroid or adenomyotic tumors, we don't see in the within the most interior portion of the uterus. And that is why I told you that the tumor of the ovary has to be evaluated more in a more vigilant way than the tumor of the uterus, because the tumors which are visible in uterus are most of the time benign tumors or non-malignant or non-cancerous tumor. The tumor which is visible in the ovary can be really very confusing. We could sense it like a non-malignant or a non-cancerous one, but finally it can turn out to be a cancerous tumor. So a tumor of the ovary has to be evaluated, has to be treated more vigilantly as compared to the fibroid or the tumor of the uterus. With all this, I think I've given you a bit of brief of the whole tumor of the ovary and tumor of the uterus. And in case if there is any question, I'm okay to take those questions. And in case if you have, if there is somebody who's having a tumor in the ovary or tumor in the uterus, rather than panicking, go to your doctor, ask them. They may be there could be nothing on which you are panicking about. So first let know what exactly it is, and then you need to panic about it or not, because most of the time they are non-cancerous, they are not cancerous tumors. Thank you. If there is any question, I'll be okay to take them. Thank you.